Oh, yes, I had to get a new telephone number today. Oh, boy. All the things. All right, Susan.
Hi, Nancy. We see Cheryl, Mary, Sherry.
Okay, here we go. Wow, we have a lot. Do we do a lot of questions? Oh, no, it's not that bad. It's only 15. Okay, great. That's good.
And I've got two submissions that Susan sent me via text
Oh, perfect, perfect,
that I'll be
perfect.
reading
Okay.
as well.
All right, so I'll have to read it to you. So it's not quite so beautiful, but we'll figure it out. Okay, let's see. So, question number one: if you cannot find a primary tumor during surgery, open duodenum, run the bowels, intraoperative ultrasound, or scans, or maybe you could type them and put them into the. Oh, that's a pain in the butt. Yeah, I
It's
forget.
take forever.
That'd take forever. Yeah. Or scans or EUS. What typically happened to the primary? Pathology can't differentiate between duodenal or pancreas. CDX2 gastrin positive, weak, SATB2 negative. Wow, that's a very specific question. Okay, so I'll try to generalize the question a little bit. So the question is, if you can't find the primary tumor, then what do you do? So in this particular situation, it's a neuroendocrine tumor. It looks like in the either the duodenum or the pancreas, so it's in the upper. So generally, we can um, there's a little bit of technique to it, and you do have to find it. But I have had very, very, very rare instances when I couldn't find the tumor, and that's good because in some ways, if it's really small and you can't find it, then it's too small to hurt you. So there is some goodness to that. The bad thing is, obviously we try to get it out, and but if it's so small, then obviously it can't be that bad. But using the dotatate scan, usually we can find it, and so in theory it should be there on dotatate, and you should be able to find it, and the map should be there. So I don't have a great answer for you in that respect, because most of the time we see it on the scan. But if you cannot, then you have to wonder if it is actually a little bit something more weird. Like could it be a prime? Like could it actually start in the liver? That is not common, but it does happen every now and then, and that could be a totally different situation and totally different biology. So tough one. That's a great way to start. Man, it's some question I can barely
Yep,
answer.
getting the hits out early,
I
right?
know, right? Since the liver can regenerate itself, is having serial lobe resections, allowing for regeneration between resections, a reasonable treatment option if metastases are only in the liver, too many to count in an otherwise healthy individual once stability stops? Wow, that's a really fascinating question. So the question is, can you just keep chopping away at the liver if it regenerates? The answer is no. Um, so the liver regenerates in very, very specific ways. So if you chop out how do I explain this? That's a hard one.
Melon ball versus section.
Right, that's the whole thing. So what Will is getting at, the way that he and I do this operation, we try to preserve as much liver as possible because we don't want to disturb the liver that's beautiful and good. The way the liver works, so this is quite a different lesson. The way the liver regenerates itself is usually what happens is you have to remove some large section of the liver, right? And whether that's the right thing or wrong thing, it depends on the situation. But you take out some big chunk of the liver, and then whatever remains just gets bigger. It's not like the whole liver grows into its old form like when you were a child or when you were born. That is not what happens. Basically, whatever's left over just kind of goes and grows. So if you had this much, and they chopped off this portion, you have this, it goes and it stops. It only grows to as much as you need it to grow. So if you kept chopping and chopping and chopping and chopping away the liver, I guess in theory, maybe it could catch up. But the problem is usually then the little tumors that are inside the liver grow. So it's not perfect. So which is why I basically stopped doing that many, many years ago. And now all I do is I just basically kind of just remove them piecemeal by piecemeal, and not piecemeal. That's the wrong word, but tumor by tumor, because then you can kind of get out the big ones, and the little ones that are stuck there are just stuck there, and that's kind of what happens. So it's not quite as easy as being able to cut away at it and then just having it grow back. Yeah, it's not quite so simple. Good thought though, but it just doesn't work that well. So my bone-on-bone knees that have been recommended replacement by my orthopedist are not approved by my net specialist due to inability to heal adequately. Is this standard protocol that neuroendocrine tumors cause inability to heal from any major surgery?
Never heard that.
I have never heard of such a thing, right? Because we do major surgery in neuroendocrine patients all the
I
time.
mean, like to remove your tumors.
Yeah, to remove your tumors.
We have to do a big, gigantic whack on. I mean, bone and bone, muscle, fat, skin, they all heal a little bit differently. But I mean, if we need to do a surgery on you, you still have net afterwards.
I know. Yeah. I don't have a great answer for you. I'm not sure why the net specialist would say that. I don't understand. Hey, do you want to give the phone to her? She can peruse it and she can interject in case anyone has any questions.
Yeah.
Yeah. Yeah. Why don't you be the peruser of things?
I mean, it's not updating super
Yeah,
fast. And
I'm sorry. I don't
know.
know why the doc would have said that. Maybe there's a specific reason. Maybe there's some sickness involved. Maybe there's tumor in the bone. I don't know. I can tell you if there's no like obvious cancer reason, I I don't stop people from getting that operation. It's not because they can't heal. It's they're usually really quite well. I don't know. I don't know. I don't know. Question 4. Is carcinoid crisis a distinct possibility with anesthesia or a rarity? It's a rarity. It's a rarity. So carcinoid crisis, just to back up a little bit, is an unusual entity. It does happen. Actually, it happens a fair amount when we do it because we're dealing with the liver and the tumors themselves. But it actually doesn't happen really that often if you're having some other procedure. So there's some thinking that if you have surgery, that every single surgery you need octreotide and the epinephrine, that whole story. I've not found that to be totally true. I've used epinephrine in many, many neuroendocrine patients and it seems to be okay. I've done small procedures in which I didn't touch the tumors and the patient was okay. It's only when you start squeezing and massaging those tumors that it secretes all this junk, and then the liver and stuff, when it becomes very complicated, the carcinoid crisis is actually much more common because we are causing it, we're inducing it, right? Because we need to get at the things. But obviously for us, we know how to manage it, so it's not really that bad. It does happen, and sometimes it becomes unmanageable. But that's not usually the situation. All right, number 5, with a quarter of a pancreas and metastases to the liver, should one continue lanreotide after completing 4 rounds of PRRT? Wow, that's a hard question to answer because I think what you're asking me is, given the fact that you have so little pancreas, is the lanreotide going to be more toxic? So what I can tell you is this. When people have PRRT or Lutathera, or whatever kind of thing they have. Oh, sure. Let me come closer. I'll come a little closer. Ugh, now you're gonna. Ugh. I don't have to be too close. Oh, goodness, look at that. Can I hide my face when I do that? All right, friends.
I can hold Yoda. I can hold Yoda in front of you. Lanreotide you'll take, even with quarter of pancreas.
Wisdom. So I think the question really is, if you had to take the lanreotide, could it actually be more of a problem? The lanreotide with the Lutathera or PRT is supposed to be helpful. So I keep the patients on it because I want to keep things as slow as possible. There was one study that came out of Scandinavia that said that if you kept them on, the people could do a little bit better for a little bit longer. And so that is why we do it. So I would, and then deal with the consequences of the lanreotide. All right, see, what are your thoughts on having proactive surgery versus waiting, especially when you've been told you will need it eventually? Without surgery, PRT is not an option because of the location in the mesentery. Okay, these are profound questions. These are hard questions today. So the question. Okay, so here's how we feel about surgery. If you're totally asymptomatic, you totally feel fine, everything is totally fine. There's no rush to surgery, right? The benefit of this situation is if you can do surgery when someone's healthy and strong, it always goes better. People are stronger, they are eating well, there's no sickness, there's no infection, they actually do better. So there is there's a lot of justification to doing the operation when you're feeling actually kind of okay. But the difference now becomes, well, you don't have to do it today, right? So you could certainly do it in a month, you could do it in 6 months, you could do it whatever, you could watch it for a while. So it gives you a lot more flexibility. But if this patient starts to get sick, then you have to start to think about it. Um, Now, without surgery, it says PRT is not an option because of the location of the mesentery. Well, if that's a situation, then you should definitely have surgery before the PRT, get that all cleaned up, and then do it. Well, I think what the question is referring to, and if anyone asks a question, they can clarify. Basically, what we have found, I didn't know this happened, but a lot of my colleagues have seen this. If they give PRT in patients whose bowels are not actually didn't have surgery and they have bowel problems, it makes the bowel problems worse. Maybe from swelling or scarring. Who knows? I don't really know what it is, but it makes the scar. Sorry, it's been a long day. It makes the blockages worse. So Will and I never saw that, or Kate and I never saw that because we would always do the surgery beforehand, right, just by routine. And so when people told me, I was like, I've never heard of such a thing before. Well, in fact, it does happen. It is true. It does happen. So having surgery beforehand is I think a little bit better, especially if you're feeling well and you really think PRT is the next step. So I think that's reasonable. Especially if they can do a minimal operation, which is not doesn't cause you too much harm.
It's like I feel like this question is preempted by like, do you need PRRT? If you need it, and you need a surgery to be able to have that, you got to have the surgery.
Yeah, right. Otherwise, it significantly increases your risk for bowel issues.
Yeah.
7, is CAPTEM a routine regimen for METs to the livers, primary ileum followed with PRT? Well, that's an interesting question. Not usually. What I can tell you is I have not been super successful with CAPTEM when it's primary small bowel neuroendocrine tumor. So when the neuroendocrine tumor comes from the intestines, I've not found it to work so great. I mean, that's just my own experience. What I can tell you is that they've tested it in mostly pancreas and stuff like that. It seems to work better for pancreas and for lung stuff, at least what I found. I haven't found it to be awesome inside small bowel. So I wouldn't bother doing the CAPTEM personally. We have some friends who have published some data from the University of Pennsylvania looking at CAPTEM combination with radioembolization. That does seem to have some kind of make a little bit of sense, but I'm not sure if the CAPTEM would really work for small bowel. All right, 8. In your experience, have you observed a higher risk of other unrelated cancers in NET patients? Well, that's an interesting question. I don't know. There are some studies that suggest that people who have neuroendocrine tumor have a higher rate of cancer above other kinds of cancers as well. I don't know the answer to the question really because the answer is kind of yes if you look in retrospect, but the question now becomes, well, those patients are under constant surveillance and they're always in the medical system and they're always going through scans and stuff, and so you find things that maybe you wouldn't otherwise find in other people. So I'm not sure if the neuroendocrine in and of itself actually is causing other cancers. That I don't know, the chicken and the egg thing. But yes, if we keep patients alive for a long time, having one cancer does not protect you from having another cancer. So it certainly can be. It certainly can be, especially when they're watched so closely. Number 9, since the move to new practice location, how do I schedule an appointment and continue care? I have no communication from Dr. Liu except the letter from Rocky Mountain Cancer. He was no longer with our practice. The only updates I get are through the group on my husband's Facebook. Yes, that is accurate. That is exactly what happened. So I'm sorry, everyone.
So we had a really nice slide built for this with like the number and she chat GPT'd everything to make sure that everything was grammatically correct and that my idiocy wasn't going to bleed through with terrible punctuation and put a little bit of work into it. So the fact that we're not able to flash that on the screen for you right now is a little bit frustrating. But,
yeah, sorry about that. We'll flash it the next time.
Yeah.
But Susan, do me a favor, if you can just get on the comments. So I'll just tell you, this is very, very simple. our telephone number, I think it's at the top of the banner, isn't it now?
I'm commenting. Oh, I don't know about that, but I'm putting it in the chat.
Okay, well, Susan, maybe we'll put it at the top of the banner. My new office number is 303-318-3464. That's the telephone number. So, Susan, maybe we can throw it in the chat, or we can, Kate will put it in the chat, and then we can put it on the banner. And just call. And it's right, the phone, you called right now, the phone would ring right now. So we've got, I think we got that all sorted out.
Probably go to answering service.
Oh, it might go to
It's
answering
after
service.
it's
Yeah,
after
it's
5
after 5
o'clock, it's going
o'clock
to the
here
answer
in
service.
Colorado, yeah.
So that number goes to. We're all sitting in a main area, so that goes just to our team. So either myself, Karina, Jennifer, or Alex.
Oh, we should take them on a tour of our office right now.
Totally can.
Yeah, we can totally do that. Okay, let me answer all the questions, and we'll take you on a quick little tour so you can see where we are. And you can see how nice it is. But that's the telephone number. Just give us a call. Okay, number 10. Can patients with metastatic functional small intestinal neuroendocrine tumors continue to have carcinoid syndrome symptoms after bowel resection and liver debulking when scans show no active disease or elevated serotonin levels? Are there tests to determine whether symptoms are from post-residual hormone secretion versus post-surgical bowel changes or other hormone secretion? Well, that's actually super interesting. So the question is, if you have a good surgery, which is good, and you can't see any tumors, which is good, and you still feel crappy, that's bad. What's the cause of feeling bad? Well, so the answer is probably not the cancer, right? Because in theory, you just removed it all. And, ooh, something's ringing on my phone. Hold on, guys. Potential spam.
Let's not
Get
answer
rid of
that. Let's not answer
Oh,
potential
my
spam.
Goodness, how many?
We'd like to talk to you about your car insurance.
I know exactly. How many times do I need that?
Have you ever used laundry detergent?
I know. With AI, it's only gonna get worse. I know that for sure. So, so that's really fascinating. So yes, in theory, if you check for the hormones, you do all the things, and you do the dotate scan, you do the scans, and you can't find any more disease. In theory, your symptoms should get much, much better. Now, it doesn't mean you've been cured, right? There could be little things here and there, but and if the little things here and there are still there and causing you problems, then you do have residual disease. And in theory, the hormone level should still be mildly elevated, but you should hopefully feel better, I would think. Then if the bowel changes can definitely be from the surgery, so then you have to eliminate that as well. So there's a whole workup and evaluation in order to kind of figure out, like, all the left and right turns if you figure this out. But in theory, you should be able to figure it out, yeah. All right, number 11. Before starting PRT, I did research and learned I shouldn't take high-dose antioxidant supplements or probiotics while on the treatment. Is that true? Are there other supplements to avoid? Is that through the whole time of the 4 treatments or just a few weeks after each infusion? Okay, so here's the question. Can you take high-dose supplements with PRT? Here's, again, the answer, of course, is I don't know, right? So there's no question that when they say you can't take it, it's because they don't want to confuse things, right? So they don't want you to be taking something else and have some kind of other problem that we don't know about. There is no, as far as we know, there is no obvious contraindication to any supplement with PRT. None. Now the question is high dose. So I don't know what a higher dose antioxidant supplement really is. Chances are it'd be fine. The problem is I don't know what the definition of higher doses of those things are. Vitamin A, vitamin C, vitamin E, Q, for example.
Are you pouring multivitamins like I used to pour Lucky Charms?
Yeah, so that's the question. Chances are it's okay. But if you want to be on the safe side, then I would probably maybe drop it down to like the regular level for a little while and then take it afterwards. And then start it up afterwards if it's been okay previously. What's something you wish every new neuroendocrine tumor patient knew, but that rarely comes up in appointments? Well, that's pretty easy. I wish that every new neuroendocrine patient knew, with a K, to go see a specialist, to go see a neuroendocrine specialist, because the way that we think about things are very different. Really what it is new neuroendocrine patients and their families and their caregivers really need to understand that they have to be the captain of the ship. The system does not does not handle rare diseases very well. It really, really does not. I wish it did. It does not. Which means that you guys have to be proactive. You've got to, get on these Facebook pages and figure out where to go and find out who you can trust and find out what the opinions are. And so it's not fair to you, but it is unfortunately a must. So I just had since we just started clinic yesterday, which was great, by the way, it worked out really well. One of the patients said he just feels very fortunate that he happens to live here in Colorado because I'm here and I can just take care of everything and everything was easy. Versus some of the other patients who had to trek all the way from Texas in order for us to see them and figure things out. But usually when they come to see us, it's not just us, but when they come to see us who really specialize in the disease, they feel a different level of comfort. Because a little bit like this, there's almost no question I can't answer. I mean, some of these like vitamin things, who knows? I don't think anyone really knows. But at least for the standard portion of it, I can explain to you. I can explain the scan, I can explain the surgery, I can explain the PRT, and explain all those things, and we can kind of study your case and put it together. So I would profoundly encourage you all to consider seeing a neuroendocrine specialist. The other thing too is there aren't that many of them, and there is no great definition of what a neuroendocrine specialist is. I would argue actually here Will and Kate now are neuroendocrine specialists because they know they've seen so much of it now, and they've heard my teachings that they understand the philosophy that I give. But not everyone has had that experience, or misfortune. I don't know what you want to call it. But it is important, and in fact, one of the things that the Healing Net Foundation is trying to do is we're trying to develop a training program so that we can train them in the ways of neuroendocrine so that they can take better care of patients. It's a heavy lift and it's a lofty project. So if any of you want to support us and either financially or with your time or whatever you want to do to volunteer with the Healing Net Foundation. Hey, is Carolyn on? Can you tell? Carolyn, are you on? If you can, just, throw a little thing up for healingnet.org. Yeah. But yeah, that's what I would say. Find someone who knows what they're talking about. And if you have to travel, I would travel. Yeah.
Wait, can I add a little bit?
Oh yeah, of course, please do.
So one thing I've noticed from the
Get closer.
the clinician perspective that we hear a lot, that I think a lot of this, as Dr. Lou said, a lot of the system doesn't understand is neuroendocrine's kind of this weird bucket of like, yes, it falls under the category of cancer and all that stuff, but it also falls under chronic disease. And so really you need to find somebody who understands that overlap and how to manage it more like a chronic disease style, as opposed to like, okay, you have a cancer, we have to do chemo, that's it. You have to find somebody like Dr. Lou who can see the big picture, understands the long runway, and not manage it like it's just a one and done, or however that looks. So yeah, I would, if you can't get in with us, I would definitely look for somebody who has that kind of mentality, understands that complex nature of those two things.
Brilliant. The wisdom.
Okay, sorry.
They are my disciples now.
I know, we've totally drank the Kool-Aid. I mean, clearly.
By the way, the Kool-Aid is Juven.
It's
so
Juven.
Sure
The Kool-Aid is Juven. If you've ever...
we both literally have drank the Juven.
I know you're going to see my face up close real. We have educational pamphlets.
This is the Kool-Aid. Yeah.
Oh my gosh.
Okay, well, that's good. How important is it when giving a lanreotide injection for the injector to flatten the skin and inject over the course of 20 seconds? And if they don't follow the procedure, is it wrong for the patient to correct the injector? That's a profound question.
You have to be your own
that's like
advocate.
Maybe I'm
correcting my wife. I don't know. Can I do that?
Like, as someone who gives these injections, I appreciate feedback, but so much of it is in how you do it. If you say like, well, so-and-so does it this way, like that, you're not going to get as good a response. So, please just be mindful. Like, I'm open to feedback, and especially if it's, something I'm not familiar with, of like, oh, actually, I thought you were supposed to give it this way. Just be nice about it.
Yeah. So here's the deal. There is no question that our healthcare system does not support these things. Part of the problem is that there's a lot of turnover, right?
Yeah.
So if you get, obviously Kate knows what she's doing. She's done this probably 1,000 times already. But if you don't have a Kate in your local clinic, you're not going to get someone who knows how to do it. So you do have to be kind of your own advocate. So sometimes what people do is they'll find that one RN who knows how to do it really efficiently and does it really well and is good and is repeatable. If you can't find that, I think you need to be your own advocate. If a healthcare provider's ego gets in the way of your well-being, then that person needs to kind of evaluate what they're doing, and allow them the room to be flabbergasted. It's like, oh my gosh, how can this patient possibly know more than I do? Except a lot of you know.
Well, and then also too, it kind of, for me personally, if somebody corrects me, I have this guilt that, oh my gosh, I just messed up and I hurt you. So some of it, that flabbergasted is being mad at yourself, not like mad at being corrected.
True. So give them the space to have that. And then, sometimes you have to, as I was about to say, was that actually sometimes it is true that the patient actually knows more than the healthcare provider. So if that's a situation and they can kind of get over that whole, oh my gosh, what did I just do wrong? Then the next time they do it, have that conversation. Maybe the right person to do it again is that same person, so that you can talk to them about it. And if they are being unpleasant, well, then right? You gave them two opportunities to do it right, and if they don't do it right the second time, then there's something wrong.
And I mean, if you wanted to escalate too, if it gets real bad, if you talk to their leadership or whatever, they can get in contact with the rep for lanreotide or octreotide, and they can come in. I mean, I had a personal one-on-one demonstration. They brought us this it looks like a little butter.
Stick of butter, yeah.
Yeah, and they had fake injectors that didn't have medicine, and we got to practice, giving it into this fake butter.
Yeah.
So there are ways to help, and that doesn't cost anything for the facility. That's and the rep usually brings the people coffee or breakfast or something like that.
So always happy to see him.
So you can also entice them, you might get some free food out of out of learning how to do it correctly.
Exactly.
I was looking at the comments, so I don't know if you covered this. It's also on us as healthcare givers to make sure that we're receptive to your needs as patients. That we are, even if it's the whatever comment that you give to us as feedback is a little bit spicy, we need to also be able to understand that we're not the one, we're giving the injection, we're not getting the injection. Our road, while it can be, difficult to feel worried that you're doing harm, it almost always got to feel worse having somebody stick, a needle in you, and doing it incorrectly than to be the one doing it incorrectly. So it's on us as much as it is on anybody else to make sure that we're receptive to your needs as patients, as our patients.
Right. So let me explain a little bit about the clinical portion of it. So the reason that unfortunately the asker of this question had this happen to them, so it's a little bit unfortunate. But the reason that we try to flatten the skin when you do lanreotide is because it's what's called a deep subcutaneous injection, which means you're not supposed to put it into the muscle. You only want it kind of in the skin portion of it because it will dissolve. And then the other part of that question was, what happens if they push too fast? Well, if you push too fast, all the drug breaks because they're crystals. So if you start shearing them and tearing them going in, you'll get a surge of it when that's not what you want. What you want is a delicate placement of the crystals so that they settle into that fat and slowly dissolve so you can absorb it over time. That is the biological kind of background of that. So that's why we do that. And if you flatten it, then you can kind of get a better sense of what the skin is. If you pinch it up, you might grab all that muscle and stick it in there too. So that's what they're trying to avoid in theory with that technique. And I think a little bit deeper, actually, one of the deeper things is I think it does demonstrate that all of you, just as the three of us are here spending our family time with you guys, we do it because we love you, we care for you, right? But at the same time, you are going to be ambassadors of our disease forever. I mean, if you have this disease, you're going to be talking about it, you're going to be teaching people, you're going to go to emergency rooms, you bring it up. Wear the zebra t-shirt. Look, I'm wearing the old zebra shoes right now. And every time that people see the zebra shoes,
I'm hugging a zebra pillow.
I know, she's hugging a zebra pillow. I mean, all these things are very, very important.
I've actually had to explain in our new space because we're technically part of the hospital, so like security makes rounds and walks by, and I've had to explain to everybody, like, he doesn't have his thing for zebras. These are all patients.
I know.
And,
They're all
like,
wonderful, wonderful gifts. I'm not insane. I always start that conversation. I'm not the guy with 20 Barbie dolls on his bed, so that's not me. That's not me. Yeah.
I will say to Dr. Liu's point too, just as a provider, I know like you said, since you have to be the ambassador, and if you understand what he said, if you push it too fast, it basically blows it up inside of you. If you can help explain that to because the nurse might not actually know that's the reason why, because we're not we're taught a lot of how but not necessarily why. So if you put it in that terms, I know if somebody explains like that to me, then it's like, oh yeah, that makes sense. I'm not going to do it again, and I'm going to remember more why.
Yeah, perfect. Great one. All right. Yeah, so we are all teaching. We are all disciples of the neuroendocrine community because we're members of the community. Okay, let's see. How do you handle high potassium levels? Oh, this is interesting. How do you handle high potassium levels while on somatostatin analogs, while you're on the shot? The glucose levels are normal, but steady potassium increases over 6 months on the shot. That's not the usual. That's not the usual. So what can happen is, okay, so the question is, so the reason that the question was asked is classically when someone is given when someone starts on the big shot, it can cause a little bit of, it doesn't usually cause frank diabetes, but it causes a little bit of a rise of your blood sugars. But this question is different because they're actually asking about potassium. So now the question really becomes, why is the potassium elevated?
Is that a
So
normal side effect?
not traditionally, and so you have to start thinking a little bit outside the box. So one of the things that could certainly be happening is maybe the patient had a little more diarrhea before. Now you're stopping up the diarrhea, and then you're kind of clogging up the potassium, and you're kind of absorbing it. That could be one. It could be another medication. So the other question, are there more medications that have come through? Kidney function, you have to make sure the kidneys are working okay. I can't think of another reason why potassium would go up specifically with the drug. I don't know. Is it working? Hey, can you guys see us? Just tell me that this is still working, because it's frozen over there too. Is it frozen on yours?
Oh, it's not playing.
Oh, it's not playing? Oh, okay,
Yeah.
okay, all right.
Yeah.
Um,
We're still getting responses.
Oh, we're getting
So,
responses, yeah, you're right.
the last response from Sarah Radke, nurse at Lou's new location knew how to give the shot. If that helps anyone feel better.
That's good news. Yeah, it's good news. Yeah, I'm not exactly sure. I think that would require a little bit more. Okay, thanks, Dan.
Thanks, Dan.
So it would have to, this would require a little bit more understanding, a little bit more evaluation and study. So I'm not sure I can answer that. But that's not traditionally what happens. All right, 15. I have personally had 6 liver embolizations over the last 6 years. Most have been bland bead. Oh, I remember. Yeah, one was Y90 and one combo bland Y90. The last 2 have been bland and were both done this year. The first 4 were fairly easy. The last 2 have been quite rough, particularly fatigue with the last one a week ago. Is there a cumulative effect as you progress with this type of treatment? So interesting. So what are the cumulative side effects of repeat embolizations to your liver? So the answer is yes, maybe. It's not so much that it's a cumulative effect, but really what the issue is that your tumors are maybe changing over time. And so the reason that you're doing those kinds of treatments may have to do with the fact that your tumors are changing. So each one may be a little bit harder because the tumors are changing, maybe you're a little bit older. I mean, those are all kind of variables. And maybe that the way they did it, the specifics of it. In general, the answer is no. In general, I've had patients that had actually multiple embolizations over the course of years and years and years, and they actually kind of tolerate it okay. They may have some pain a little bit more here and there, kind of depending on how hard they go with the embolizations and stuff like that. But in general, it's actually still pretty well tolerated. But what does change really is the nature of the disease and stuff like that. So a little hard to answer specifically for this for whoever asked the question, but the answer is, yeah, maybe the answer is yes and no. I guess because everyone's a little bit different and the biology of the cancer changes. So, well, there you go. That was 15. Not too bad.
Yeah.
And also, real quick, back to the injection stuff. With our new clinic and new
Here, come.
setup,
Come closer so they can hear you.
with our new clinic and new setup, everybody's going to go through the infusion center. So it won't be myself or our new nurse, Caitlin, who will be starting in a couple weeks. It won't be one of us. It'll be our wonderful infusion team.
Yeah. Well,
So
should we take the
people-
gang on a little tour?
So we've got 2 more questions that were
Oh, sorry,
submitted
sorry,
after the
yeah.
initial. The first is, I have had 3 CT scans on a carotid body paraganglioma, and in each one, the size varies on the report. Is this to be expected depending on the individual reading the images?
I'm not sure it has to do with the individual reading the images. I think it has more to do with the fact that the images are imperfect. So what happens is when you take a bunch of pictures, it's a series of slices, and kind of depending on where in the paraganglioma, which is a little neuroendocrine tumor, sits kind of here in the corner of your neck. It's usually oval. It's not always perfectly round, so sometimes it'll change a little bit. So it has to really change a fair amount before you can really call it either growing or not growing. So there's a little bit of interpretation. The radiologists like to give themselves, it's pretty generous, but they give themselves about 20% space to be wrong up or down, kind of depending on whether or not it's really changing. If the measurements are all within about 20% of each other, up and down, right? So if it keeps going up 20%, that's a problem. But if they're just kind of like within 20%, then that's pretty close, and then we would say that the disease is stable.
So last question is, many NET patients are on B12 supplements. Do you have a recommended amount, or is it based only on blood work? If platelet levels are low, when does it become a concern?
Okay. Well, true. A lot of patients are on B12 because they've had surgery, so they don't absorb B12 naturally from their food. And I'm totally okay with that. People take shots. Some people take it orally, but the shots actually work really quite well. It depends on blood work. So for some people, it makes them feel better. So if they feel better, I don't fight them. B12 is not expensive. I just give it to them.
It's 94 cents.
Is it really?
Yeah.
Is it 94
Because
cents?
somebody at the old clinic, insurance didn't approve at the last minute, and then so pharmacy looked up the price, and they're like, it's 94 cents.
And they were like, keep the change.
Yeah, they're joking. It's like, I can go without insurance.
You can afford that? That's so funny.
Yeah.
So yeah, so the B12 is a good thing, but we can also measure B12 levels. So if the B12 level is pretty high, it may or may not be helpful in making you feel better, unless it does. What's actually a little bit more challenging sometimes is trying to pin down what the causes of these things are. So if you have lost some bowel, that can be an issue. If you're not absorbing food very well, that can be an issue. So we can follow the bloods, but it's really about how you feel. But when it comes to the platelet thing, so in general, the B12 and the platelet thing don't have a super connection. B12 is more about anemia and red blood cells and iron and hemoglobin and stuff like that. It's more on the red side. The platelet side of it is not usually related to the B12. But the B12 may be a symbol of you just not absorbing food very well. And so then the platelets can be a problem. But usually the platelets aren't an issue when it comes out, unless you're doing a bunch of injections and you bruise, right? So platelets, if you have low platelets, you'll bruise a lot and maybe bleed. But generally, the B12 is not associated with the platelets. It's more with the red blood cells.
Can I do a cheap plug?
Please, come in.
So, I'm learning about all of our resources that we have now available that we didn't before. And the big things that we have are access to nutrition. We have 2 nutritionists on site. It's not an extra cost to see the nutritionist. So we're hoping to utilize them more and get you, we can potentially get you in to see with them, and you can work with them on all this as well. And we also have physical therapy now, so we're trying to, build out a more comprehensive program.
which is all I wanted to do.
I know, seeds.
It's like the entire freaking time.
Yeah.
I know.
So, but I just wanted
Take
to
better
make
care of you
it
guys.
clear that nutrition is included. So we
Yeah, that's a great plug. Great
Yeah.
use case.
So
Okay.
sorry, since you're talking about
No,
vitamins. I was like,
no
"Oh,
no
come into that."
apology. Yeah, wonderful. All right, so Mimi asks, are you set up for televisits? The answer is not really. So a little bit like I think I may have said it last time, so I'm sorry if I'm repeating myself. But basically, these televisit laws have become a little bit more complicated, and it's not me, it's the state. And so getting licenses is not a big deal, but trying to figure out which states are open to doing telemedicine and which are not is a little bit more complicated. So we are working, I promise you. I think probably in the next month or two we may have a little bit more information about that.
Oh, more information.
Yeah, we may have more information about that, but for now we're a little bit stuck with just whatever we can do. So I think in the short term I'm gonna need more people to actually come to Colorado, like we did before COVID. And then as we begin to expand, we'll figure it out. But I mean, it would be great if let's pretend Congress could like pass a law where telemedicine was legal. That would be awesome. But let's pretend Congress could do anything. Exactly. So that's the problem. So I mean, look, for those of you who are voting, see if they'll take your vote. Yeah. All right. Any other questions on the?
I didn't
Chat?
see anything from chat specifically, or a few comments.
Oh,
What-
thank you, Mary, for putting in all of our info. You had everything correct except for our fax number.
Oh, then that was my fault. Yeah, I actually got the fax number wrong. So I think it's 303-318-3437. 3437. Yeah, I'm sorry. Yeah, I
I
apologize.
responded under Will.
Yeah, my fault. I'm so sorry. Let's see here.
Sue Blackburn, I always talk to nurse administrating the shot, ask if they've given before. If they give slowly over 20 minutes, sure that
20 seconds. 20 seconds.
20 seconds.
Yeah, it should be 20 seconds. Yeah.
Yeah, she did correct it. Assure that it's not personal. They're always nice and thankful for discussion.
Good,
20-minute
good.
shot.
Oh,
No!
That's a full episode.
Put
of,
me to sleep
of The
first.
Simpsons.
that's
Seriously.
terrible on both sides.
That's
I
awful
know.
for everyone. Let's see.
David,
David
yeah.
Spar or Spar? Is that a? I was recently researching autophagy, autophagy and cancer, and something caught my eye. Some tumors can cause the non-tumor cells around them to start acting like primary location tumor cells. If NETs do that, it would make sense that resection might get most of the tumor cells, but maybe the healthy cells left behind are now creating serotonin themselves, i.e., serotonin syndrome, even with NED.
Probably not. That's probably not the situation, David. So what is more likely, and so it kind of depends on what the situation is the more likely thing is it was multifocal disease to begin with, and we just didn't catch all the little things that were there. So that's probably the more likely scenario than to get the cells to change, because you can have tumors there and right next to it, like literally microscopically next to it, the cell is exactly the same. So I would be very hard pressed to think that it transformed the other cells, because if the other cells ate the neuroendocrine cells, then that would be very strange. That does not usually happen, because generally neuroendocrine tumors are actually quite resistant immunologically. They're very, very hardy, and they're what we call an immunologic desert. They don't really stimulate a lot of immunology, which is why our immunologic drugs don't work awesomely for them. So it's a little bit of both, but a very interesting idea. But I don't think that's what's going on. Let's see. It took me about 2 months before I felt better after surgery. Yeah, I attribute the hormones effects leaving the body. Yeah, all true. One thing that Ken always says that he teaches us is that, I don't know, Ken, if you're on, but what happens is people become so sick that they don't eventually realize how sick they've become, right? It's become like this, and the new normal is really pretty miserable. So getting them out of it and digging them out of the ditch is actually a pretty tough thing to do. Yeah. All right, we should walk around real quick.
Yeah,
Yeah.
Yeah, just take it.
And one thing with with the clinic, we really appreciate your patience. I know everybody wants to get in and see him. We all just started within the last week or two, so yes, we know how to help take care of you, but this is a completely new system for us, and we all have to get up to date. And the biggest piece of it is that's new for us is we have to do a lot of the heavy lifting for insurance stuff and figuring
Yeah.
out what's covered and what's not. So that's some of the delay in getting you scheduled, is because we have to we're really slow at checking insurance because it's new to us. So that's probably actually the biggest barrier to get people in right now.
Yeah. Here, why don't you take the computer and have Kate give a tour?
Sure.
Our lovely tour guide, Kate.
Oh, I want to be a tour guide.
I'm just gonna be cameraman right now.
All right. So yes, as you can see, we've already exploded, taking over with zebras. So yeah, so this, you know, in all our zebra rocks, you might recognize all the accoutrement that came from his office and from before, and we're also stealing books that were left behind. So Dr. Lou might do a side thing in plastic surgery, you know, if anybody's in.
I promise you that. But we
The
have
amount
yeah, go ahead.
I was gonna say the amount of people over the years I've heard people say, like, when they get their gallbladder, their appendix out, like, while you're in there, do you just want to, you know, like, maybe tighten things up, or
Give
you
me
know,
my nip
like,
tuck. My nip tuck.
you know, just but yeah, so you can see we're all here in a little bullpen area. We're all together. And we're in an open shared space now. Jennifer is off here. Don't show too much because, you know, don't know what she's exposed. But yeah, shared office situation. Well, I don't want to accidentally say something.
Yeah.
No,
And then
you're
we have
fine, you're
all
fine.
We've
these
got exam room, so yeah, we're in a really, it's a great situation.
And something that's new, that'll be new here, is that we will actually, Dr. Lou will pull up your scans on the computer in the room, instead of pulling it into your office, because you saw his office is shared. Once Eleanor starts, she'll be in there too, and it's a tight spot. So we will do, this is where you will sit, but you can see it's brand new. This place only opened up in February, so everything's like very nice. I mean, the building was just built.
Yeah,
so.
it was just built, so everything's brand new. All right, friends. Well, that's pretty much it. As always, go out there, preach the gospel of neuroendocrine. If you can support the Healing Net Foundation, please do, either with your time, your support, your education, your thoughts, anything would be great. So sorry about the little weird technical issues. We'll try to figure it out. But you guys, everyone, be well, be safe, and we'll see you next month.
And keep trying to call. We know that there's been some dropped calls and some calls that haven't been returned yet. Just keep trying. We're working on it.
Part of the problem that we're just getting fixed right now is the way our phones set up. For some reason, they automatically go to voicemail after like 1 to 2 rings. So we're working on it. So we don't even have a chance to answer the phone. So we're trying.
So anecdotally, just really quickly, one of the staff members here who's been with Dr. Lou for a little more than a year now was speaking with the administrators for the hospital that we'll be working out of primarily, and they found out that she was working with Dr. Lou. They were so excited. Oh my gosh, this is amazing. This is amazing. You broke our phones.
Yeah, it did happen. I warned them. All right, you guys. Happy 4th of July. Be well, be safe. We'll see you next month, okay? Bye, everyone.